She runs a GI-focused private practice specializing in treating inflammatory bowel disease, IBS, SIBO, and many other functional GI disorders. She does a lot of teaching and speaking on conventional and natural treatments for gastrointestinal conditions. Is really a good example of an integrated model of healthcare practice. She is an expert on this intersection of IBD and IBS as well, and how treating one can help resolve the other. She's also a mentor to naturopathic and functional medicine practitioners. She supervises residents in her practice, and she's been a top doc in Portland Monthly Magazine several years. Hey, Ilana, welcome.
Thanks.
Appreciate it very, very, very much. This is another lecture that is really going to help me in particular. So this is, you can just, it's like I could have my own private lecture here, and I would be, it would be worth it. But fortunately, everybody else gets to hear you too. We have over 120 registrants, about, let's see, about 90 here on the spot at the moment. The rest will listen to your recording while they're, doing who knows what else. So, thank you for joining us, and take it away. I think you have what, an hour? I know, and you're up for that because you're a good, fast, efficient talker.
That's a word. That's a description. And Tori, I don't know if I'm going to have time for Q&A. So if you want to cut me off at some point to switch over to Q&A, that's totally fine.
Okay.
So today I am going to talk about, I think, a really, really important topic. And it's a condition that I feel like we see all the time, but we don't even know it exists. And we actually put the blame on other conditions because we don't know this condition exists. And that's exocrine pancreas insufficiency. The first thing. Oh, so I am Dr. Gurivich. I just want to point out that I have these 5 awesome letters after my name, that I am now officially a fellow from the American Board of Naturopathic Gastroenterology. That is a thing now. We do offer naturopathic gastroenterology board exams. So if you guys are interested or curious, you can check out the Gastro Association of Naturopathic Physicians. But it is, we just launched the exam last year. And so there's, I think, 12 FABNAGs out there, including me. Financial disclosures. So I do host residency positions. I'm under the NERC umbrella, and I do get sponsorship from both Diagnostic Solutions Lab and Enzyme Science. And as of yesterday, I am a physician educator and a speaker for Nestle Health Science under their ZenPet product. That was just a training that I did yesterday. But that's an interesting way to kind of marry my talk today, because both of those things are there to treat exocrine pancreas insufficiency. So what are my goals? My goals are that you understand the pathophysiology, the underlying causes, symptoms, testing options, and most importantly, treatment options. I really want to talk about, I'm going to give you guys a quick download on the PERT pharmaceutical aspect of treatment. But what I really want to dive into in this talk is actually the vegetarian options for treatment, because I feel like all of us are exposed to different vegetarian enzyme supplements, but if you guys are anything like me, you have no idea what's in them and why you're prescribing them and what conditions they're useful for. So I really want to do a good download on that so you guys can understand what you're looking at when you're reading labels. So first things first, we always talk about physiology. What should the body be doing if everything is running naturally? So everything about this talk is going to be rooted in pancreatic function. The pancreas has 2 glands within one organ. There's the endocrine and the exocrine. The endocrine is usually what we talk about in medicine because we talk about diabetes, type 1, type 1.5, and type 2 diabetes. The endocrine portion of the pancreas are mainly the islets of Langerhans, and they secrete hormones directly into the bloodstream. So this is a hormone endocrine organ. Mainly it secretes, the endocrine function secretes insulin and glucagon, which regulates glucose either to bring it up or to bring it down. And then somatostatin, which controls insulin through a different pathway. The endocrine part of the pancreas is 15% of the organ. The exocrine part of the pancreas is 85% of the function of the organ. It's a huge portion in digestion. And I think that we often forget about it because until recently, the drugs were kind of boring, to be honest. So, there was no TikTok advertisements about exocrine pancreas. The exocrine part of the organ secretes enzymes. There's a direct duct, the pancreatic duct, that dumps those enzymes and pancreatic juices into the duodenum. And those enzymes help break down carbohydrates, fats, proteins. And then there's also a portion of the exocrine pancreas that secretes bicarb and water to neutralize the stomach acid. Stomach tissue is a lot more resilient than small bowel tissue. And so if there wasn't an option to neutralize the very, very acidic chyme that comes out of the stomach, our duodenum would end up getting ulcerated and burned. The exocrine portion of the pancreas is 85% of the organ. If everything was working ideally and normally, the exocrine would secrete lipase, elastase, amylase, trypsin, and chymotrypsin. Lipase for fats, elastase as a secondary marker to break down mainly proteins, amylase for carbs, and then trypsin and chymotrypsin are other protein markers, or protein enzymes, sorry. I love this picture because it really just gives us an image on what's happening with inhibition and secretion. So in the stomach, let me see, do I have a pointer? Tori, can you see or no?
Yes.
Yes, you can see my pointer?
Yes.
Okay, great.
Yes, we can. Looks
Great,
good.
thanks. Okay, so the stomach, when food comes into the stomach and it mixes with the acid, that's called chyme. That chyme will then go into the duodenum. When it passes into the duodenum, the body will recognize that there are both protein and fat within there, and cholecystokinin will get secreted. Cholecystokinin will go up to the bile, up to the gallbladder, to secrete bile, and cholecystokinin will go to the pancreas to secrete enzymes. Secretin will also get sensed. Secretin will go to the pancreas to secrete bicarb and water, and then the intestine will mix all of those different enzymes with the chyme, and it will start the digestive process. The other thing that happens is when there's enough food secreted into the small bowel, there will be a hormone that stops the stomach from dumping. The stomach is this kind of incredible organ that not only is an active digestive organ, but is also a storage organ. And so the stomach will be able to slowly drip out food to allow the enzymes and the bile to mix with that food to begin digestion. It'll let the food move down the intestinal lining, and then it'll secrete a little bit more food to start that process again. It's really, I think the stomach is literally the only organ that has a function and a storage. I can't think of any other organ that stores, just lets it hang out. Maybe the liver with blood a little bit, but not as much as the stomach. And proper digestion, it's key to get that proper mixture of that chyme with the enzymes and the secretions. When do you get symptoms? When something in this beautiful orchestra doesn't work. When something in this beautiful orchestra doesn't work, it's called exocrine pancreas insufficiency, or EPI. EPI is defined as inadequate activity of pancreatic enzymes in the lumen, and that will lead to either maldigestion, malabsorption, or both. What are the symptoms? Diarrhea, steatorrhea, abdominal discomfort, bloating, weight loss, malnutrition, and if it goes on for a long time, trace element and vitamin deficiencies. What is the problem with all of these symptoms? They basically sound like every other functional GI disorder that we see in clinic, including SIBO, including SIFO, including a nervous stomach. They also sound a whole hell of a lot like Crohn's disease, like celiac disease, like ulcerative colitis. The problem with EPI is it literally could be a component of virtually every condition, and we rarely think of it as the primary issue. We often think of it as part of what's happening with other diseases, and it absolutely is part of what's happening with other diseases, but it is also at times the primary issue. What's the risk? So the risk of untreated persistent EPI really comes down to nutrients. The first thing is, if if the pancreas is not secreting enough lipase, then all of a sudden you cannot absorb any of your fat solubles, vitamin A, D, E, and K. That's bad. The only thing that's worse than that is if that happens persistently, now you can't absorb any of your nutrients. You can't absorb minerals. You can't absorb calcium, folate, magnesium, any of the Bs or zinc. And if that goes on for a long time, you end up having metabolic bone disease. And that is just a long-term risk factor that has a whole lot of other issues as we age. And so really the big thing about chronic EPI is the fact that we can't absorb our D, we can't absorb our K. That will lead to osteoporosis or osteopenia. And so it's really important when you see a patient in your office and you kind of put together that they have EPI, you need to figure out how long they've had it for, and you do need to refer over to a DEXA to see if that is their problem. If the problem is that they also have osteoporosis and osteopenia, and if they do, not only do you have to address the EPI, but you also have to supplement with other nutritional agents, fat soluble and water soluble, because of the risk. So this is my favorite topic. I feel like I can talk about steatorrhea for hours. I feel like it's more fun to talk about it at a live setting because I can see people's faces get disgusted as I describe the steatorrhea poop. But see, I don't think we ask our patients enough about the quality of their stool. When I was in school, I learned that steatorrhea, like a floating stool, meant fat malabsorption. So if the stool floats in the top of the toilet, that is a fat malabsorption marker. And that is actually not correct. Stool can float on top of the toilet bowl for a lot of reasons. Fat is one of them, but they can also float because there's too much air, high fiber, different dietary choices. So a floating stool does not give us enough information on if they're absorbing their fats or not. The sign that we are looking for, that I feel like we should be asking patients, is when they flush their toilet, is it a one and done flush and the toilet bowl is clean, or are there little islands of poop that are sticking on the porcelain? Because, you know, fat repels water. And if they have a stool that's really high in fat, it's going to end up sticking to the toilet, and the water of the toilet bowl mixing is not going to be able to get rid of it. So if you are suspecting steatorrhea, the follow-up question is, after you're done having a bowel movement, is it a flush and you're done? And is it a courtesy wipe, like you wipe once totally clean, or is it greasy and you have to wipe a bunch? That is a sign of steatorrhea. Steatorrhea can be caused by exocrine pancreatic insufficiency and also bile acid malabsorption, and also to eating just an excessive amount of fat. So, you know, I was talking earlier that EPI is its own individual diagnosis, but it's also a diagnosis that comes with a lot of different conditions. The most obvious conditions that we just should obviously assume they have EPI is cystic fibrosis. That one's just a given. And a lot of the data on actually the EPI pharmaceuticals are with cystic fibrosis patients. Chronic and acute pancreatitis, any pancreatic damage or pancreatic cancers, metabolic diseases like diabetes. I think that at some point in practice, I kind of made this realization when if the islet cells, if the alpha cells of the pancreas aren't working, then probably the beta cells are not working either. So the exocrine portion of that gland is also not as robust as it should be. So with metabolic disease like diabetes, we have to do more legwork to see if there is a EPI component. You can absolutely have it in digestive dysbiosis, small intestinal bacterial overgrowth, small intestinal fungal overgrowth, dairy sensitivities, and then any of the malnutrition diseases, celiac, inflammatory bowel disease. You can absolutely get EPI if you've had some kind of asynchrony of the nervous system to innervate the intestine, like a gastric bypass, or like some kind of inadequate enteropancreatic feedback loop with the nerves. It can occur just with aging. And it can occur with certain foods that cause you to have diarrhea. So certain dietary malabsorption issues. Testing. There is great testing for EPI, actually. Great testing for EPI. That's not true for bile acid malabsorption. So, as in the naturopathic world, we are constantly, we have abundance of tests to choose from. Some of those tests have been well validated, and some of those tests are garbage. And unless you have, a couple of extra hours in your day to do a bunch of lit searches to find out if a test is bunk or not, and if you should be basing clinical decisions on it, one of the easiest things to do is just pop into PubMed, which is what I did here. I did it mid-2022, and I put in fecal elastase. And I was wondering how many papers have been published and how many of those papers have been published using human data. And so there were 651 papers published on a fecal elastase, and 545 of them were using human data. For me, like, even before you go in and read those 600 papers, that's a pretty good guesstimate that this is a test that's been well validated. And it is a test that has been very well validated. The test is either a fecal elastase 1, pancreatic elastase 1. It goes by a bunch of different names, but it's all the same test. Basically, what it's looking at is there an inability for the exocrine pancreas to produce or transport enough enzymes to break down food in the intestine and to get you in trouble with absorption of nutrients? This test is really, really valid for a variety of reasons. The first that's really important is it's stable for 7 days. So you can have them drop off a sample. I think it does have to be refrigerated, but it does not seem to change on day 1 versus day 7, which is great because sometimes labs take a long time to run things. Also, this is a test that we see on a lot of our functional labs, and we know that those samples are getting sent across the country somewhere and getting processed. And so we can kind of rest assured if our fecal elastase 1 is low, that's an accurate test. This test was verified by the gold standard, which nobody does, but that's called a duodenal secretions via secretin Corlin test. So the way that this test works, and it's important that I tell you how this test works because we have an answer to how it works in the studies, but I know as a fact, that's not what they do in clinical practice. So in the studies, the gold standard, if you think that somebody has a pancreatic insufficiency, is you sedate them like you're doing an endoscopy, and you insert your probe, and then you insert an IV of secretin for 2 hours. And what you do is you collect your duodenal juices at baseline, and then you collect your duodenal juices every 15 minutes for the next 2 hours to measure bicarb, amylase, trypsin, lipase, and elastase. So basically, you're really looking at what is the pancreas secreting. What happens it's a test that goes on for 2 hours, so they do a collection every 15 minutes. What I have had one patient have their gastroenterologist run the IV duodenal secretin Corlin test. What happened in that particular example was the patient, we finally diagnosed her with EPI. I think she had elastase of like less than 15, and normal elastase is 200 or higher. And we ran a functional stool test that came back as less than 15. And then we ran again through one of the standard labs just to make sure that it wasn't a false negative. Again, I think that one came back at 7. And so I sent her back to the gastro to kind of figure out what's happening. The gastro puts her on the table. She does an endoscopy. She gives her 1 shot of 1 IV push of secretin, takes her digestive juices right then and there. They were all present. She was like, okay, you're negative. So she did not track her over the 2 hours, which is appropriate, because if a gastroenterologist is doing a scope, she's got about 15 minutes for that patient. She cashes out at $5,000 before she goes to the next patient and gets her next $5,000 to do endoscopy, colonoscopy. So she was considered normal, even though the test wasn't properly done. And so, that's important to know if you're sending your patients for a bigger workup. So fecal elastase, so under normal physiology, pancreatic juices are secreted somewhere between 170 to 360 micrograms per mil. And the elastase is 93% specific and 93% sensitive for moderate to severe EPI. However, the other really special thing about the fecal elastase test is it does not cross-react with enzyme supplementation. So if they're on PERT pharmaceutically, or we're using any of our supplements, the fecal elastase will still be an accurate test. That is not at all true for some of the other markers that we have, like alpha chymotrypsin is an example of one, where the body doesn't separate endogenous from exogenous, and they have to stop their PERT, and that's a problem symptomatically because they have a whole lot of diarrhea. Elastase is measured in the stool. This is a stool collection. Doesn't have to be any time of day, but the quality of the stool does matter. If the stool is more watery or liquidy, you might have false decreases of the elastase. And again, we're trying to cross this 200 nanogram threshold. And, you know, depending on the data, some data even says the elastase wants to be over 500. But if the stool is watery and dilute, that's going to falsely suppress. And so we might get a false positive. What I always tell my patients about this is I always educate them before we run the test to, if they can, try to get a solid form stool. And I will say patients usually know when their stool is going to be really, really loose or runny. And so if you educate them that that's the sample we want, you're more likely to not get any false positives. Elastase is definitely much more sensitive for moderate to severe pancreatic insufficiency. If we're looking at a mild EPI, we're looking at something around 63% sensitivity. The fullest picture of what's happening with fat malabsorption is pairing an elastase with a fecal fat. The problem is really it's pairing an elastase with a quantitative fecal fat, which it's just really hard to get compliance with because we put patients on a lot of diet for that, and the diet is not easy to do. And it's very, very stable day to day. So, you know, if we test their elastase on Monday and again on Thursday, it's going to look pretty similar. So that's the diagnosis. Now let's talk about the treatments. So basically, the treatment is PERT, pancreatic enzyme replacement therapy. It really is that simple. We are trying to get enzymes into the small intestine where they should be while digestion is happening, and for some reason, their endogenous enzymes are not going there. So we supplement with enzymes during a point of time when they're eating to help them break down their fats, their proteins, and their carbs. We have both pharmaceutical options and natural options that are exactly the same. They're exactly the same. The pharmaceutical options and the natural options, honestly, the animal-based enzymes are generally based on pig pancreas. The natural options are generally based on, or the vegan options are generally based on Aspergillus fungi, but they also might be based on plant matter and bacterial matter, bacterially created enzymes. So it's a pork product. We're going to start with the animal-based enzymes. They are all based on porcine. And that's important to know because if there is a religious issue, if there is a dietary issue like being a vegetarian or vegan, or if there is some kind of allergy to pork, you need to be aware that they're not going to be a great fit for this type of treatments. The other thing about the animal-based enzymes is they have a really, really narrow active pH. They really, the animal-based enzymes are active between a pH of 6.8 to 8. So basically, they need to start working in the duodenum. They should be taken immediately with or immediately after a meal. That's the only time when you should be able to take them. If you take them too far after a meal, or if you take them on an empty stomach, you're just wasting money because you're not getting any of the therapeutic effect. When we're talking about so the drug is called pancreolipase. When we're talking about pancreolipase, that the drug name, each medication is going to tell you a dose for lipase, protease, and amylase. And they're all going to be shown like this, 3/10/14. So that's a breakdown of the units of lipase, the units of protease, and the units of amylase in that order. We have a range, literally, there's a range from as low as 3,000 units of lipase to 40,000 units of lipase. And that is every single pancreolipase drug. And right now, I think that there are 5 pancreolipase drugs on the market, supplied by 5 different drug companies. And there is 2 pancreolipase supplements, which is exactly the same as the drug, but not as much variability in the dosing. They're all going to be based on units of lipase. And that really comes down to the fact that we have there's significantly more risk not breaking down your lipids as compared to breaking down your carbs and proteins, mainly because of those fat-soluble vitamins. We have no way around the breaking down the fat-soluble vitamins. And so that really is the issue. So we're always the lipase is going to be like the king in this trio. How to take them. Enzymes need to be administered directly with or before a meal, or maybe directly after, but honestly, you were a little bit late. We want to get the enzymes in there as soon as possible. So by the time the food gets to the small intestine, the enzymes are there to start doing its job and breaking down all the nutrients. It is not atypical to divide the pills. You take a couple before you eat, a couple in the middle of your meal, maybe a couple at the end of your meal. Or you take a few bites, then take your supplements. What you're looking for, because we're going to talk in a minute, but dose is fairly wide. What you're looking for is improvement in visible fat in the stool. So fat-soluble vitamins, improvement in their fat-soluble vitamins, in their muscle strength, in their nutritional indices. And then if they are not showing an improvement, the first question you need to ask is, when are you taking your enzymes? The second question you need to ask is, are you taking enough of them? Enzyme supplementation was also seen to improve abdominal pain, flatulence, and consistency of stool, having less diarrhea and more formed stools. This was a super interesting study to me. So this study was looking at PERT, so enzymes, porcine enzymes, in healthy adults who complained of some, IBS-y-like symptoms: bloating, gas, pain, nausea, sensation of fullness, and then passage of stool through the rectum. So healthy adults that they did not have any EPI that they knew of. And what they did is they gave these healthy adults a 185-gram cookie. The cookie was 1,100 calories and had 72 grams of fat. That is either the most delicious cookie on the planet or really gross. What we see is dark is no PERT intervention, shaded is PERT intervention. So they were given a test meal, and then they talked about their symptoms from test meal to dinner, and then they were given a dinner and the dinner till bedtime. And what we see is for a healthy adult, supplementing enzymes decreased pretty significantly their bloating, their gas, their pain, their nausea, a lot, their sensation of fullness over time, and then the amount of bowel movements and the health of their bowel movements. So that's a completely healthy, not EPI patient. So imagine if you had somebody who actually had symptoms. So the other thing that's interesting to know is what is how much does the body naturally secrete lipase with meals? And, I think depending on what data set you look at, it's a little bit all over the place. I've seen as low as 40,000 units per meal and as high as 900,000 units per meal. The study that I grabbed this one from was saying on average 90,000 USPs of animal-based lipase per meal. It's important to know that you don't necessarily need to supplement all 90,000 units of that lipase to get proper digestion, because EPI is a gradient. So you might, depending on the fat in the meal, they might be able to secrete enough lipase to cover some of their some of their fat in the meal, or you might need to supplement more. On average, right now, they're saying the American College of Gastroenterology, their recommendation for EPI is around 40,000 units. Here's what I don't know. What I don't know is, the American College of Gastroenterology released this position paper or opinion paper with the top leaders in the field. What I don't know is how many of those leaders were being paid by the drugs that have a 40,000 unit pill, because that's the thing about a position paper is they're giving you best practices, but it's best practices based on opinions. But that is the current recommendation from the American College of Gastroenterology, is to start at about 40,000 units. So that's the PERT, that's the drug, that's the animal-based. We have a lot of basis for vegetarian enzymes as well. Plant-based enzymes are kind of their own thing. They're a completely different beast. Plant-based enzymes are generally derived from Aspergillus, which is generally made, Aspergillus is a fungus. And so it's important to know, and this is a question that I do have patients ask me. We have a lot of mold patients in Portland. We have a lot of mold sensitive people in the country, and they're always going to say, is there, well, I know that these vegan enzymes are fungally derived. Is there any fungus left in the plant matter? Oftentimes these enzymes are grown on fermentation tanks where they're letting the fungus kind of grow. And then they go through this generally very rigorous process to try to get all the fungus out of it. So by the time we're getting it in a supplement, we're no longer having a fungal plant. There's no fungus left in the enzyme. It's just really the active constituent of the enzymes. The other thing about the vegetarian enzymes is they have this huge pH range, somewhere between 2 to 12. And so, the animal-based ones, 6.8 to 8, very, very narrow. You have to be really good about taking it with food. That is not so true with the vegetarian ones. They work somewhere between pH 2 to 12. They have different activity depending on the pH, and they start working up in the stomach and they go through the whole GI system. And that's important because one of the, if you talk to some of the manufacturers of the PERT products, the pancrealipase, what they will tell you is, they have to be pH controlled because we really want the enzymes to only act directly on the small bowel in the duodenum. So we need to pH balance it. So that's when it's working. That's not true with the vegetarian enzymes. They have this really, really broad efficacy. The other thing about the vegetarian enzymes is they also help clean up the brush border. And so what that means is that, when you're eating food, they'll help the digestive process, but they'll also just do a deep clean of the brush border in the small intestine. So they're more ready to deal with food when it comes through. They also will play a role in breaking down biofilms. And they do have efficacy in biofilms in the GI and just biofilms in the whole system. So why Aspergillus? Aspergillus, it's a readily available fungus, and it mimics the enzyme production, mimics enzymes that are made in our own body. So Aspergillus will secrete enzymes as part of its normal metabolic process. Depending on what company you talk to, they'll discuss how they have different purification steps to really remove the enzyme remove the fungus from the enzyme. And we also have some commercially available enzymes that come from bacteria, just none of the ones I'm going to talk about today. And those are usually the serrapeptidase classes. So when we're talking about vegan, we're really talking about 3 sources of enzymes: fungal, bacterial, fruit. Fruit, we mean papaya, pineapple, and kiwi. Most of the ones that I'm going to talk about are fungus. The fungal ones are stable through a broad pH range. They have a bunch of different plant matter and animal matter that they work on, and we can do a little bit of a better job making sure we're cleanly sourcing it because it's all made in the lab as opposed to from an animal. This is one of my favorite pictures because it really gives a good image of the different pHs in different parts of our digestive system. So, upper stomach is somewhere between 4 to 6, and then the large intestine gets down to 7. Lower stomach has a pH of 1.5 to 4, because that's when all the acid is being secreted. And so we have this variety of pHs, and the PERT really just works in the pH 6.8 to 8. So they're really working small bowel mainly. The vegetarian enzymes are working all throughout the system. And, depending on what we're digesting and where we are in our digestive process, different supports are needed. When we're talking about enzymes, we're talking about pH, substrate, and temperature. So the substrate, we're going to do a deep dive in a minute. But the enzymes are very specific with what the environment that they're in, and they can kind of mitigate their reactions based on the pH of where they are at. They are able to break things down and continue that breaking down process throughout. And, depending on your formulation, it's going to be more targeted to certain foods than others. When we're talking about enzyme families, we're talking about protease, which is generally breaking down animals, dairy, and some plant proteins. And really, it's good. Proteases are good to break down proteins and also some kind of infections. Lipases, we've talked about, which is basically fat. We want to make sure that the body's not taking up too much lipase, because that can cause lipids to, deposit within the cardiovascular system. And so that can have some negative cardiovascular effects. Amylases are carbs. That's fruits, grains, and sugars. And then also amylases play a role in histamine balances. And then cellulases. Cellulases are basically fiber of plant matter. And so we support breakdown of fibrous materials in the gut. Out of all 4 of these, cellulases are the only ones that are not endogenous. They're strictly exogenous. So I want to pause here for a minute, because I think this is maybe the most important slide I'm going to give to you guys. So vegan enzymes are measured not in USPs, but rather in FCCs, Food Chemical Codex. It's an international standard of measuring different types of enzymes. And basically, so one of the reasons why I wanted to dive into this talk in particular is because I would pick up a bottle of enzymes and I would be like, why is this one telling me in HUTs, but this one's telling me in DOs, and this one's telling me in WHOs, and this one's telling me in FCCLUs, like this one's in, the one thing you can say about the drugs is they're all standardized to be a USP. That's a standardized thing. So I could actually compare apples to apples. And that's not true with our enzymes. Like most of the naturopathic enzymes that we're using have a ton of different units on them. And so I have tracked down how to convert these units, which I think for me actually made a huge difference. So I can actually compare different products unit per unit. And we're going to get into like what different enzymes we need for different dietary issues. And so I can compare product A to product B to get the most enzyme that I'm looking for their GI issues. So 1 HUT is 6.5 USPs. For amylase, 1 DO is 48 USPs. And then for lipase, the best we can have is FIP. There isn't a great conversion to USP. So that's a bummer for lipase. How to take the enzymes. Vegetarian enzymes can be taken at any time in the meal. You can also take them right before the meal or on an empty stomach. You're going to do the empty stomach if you're worried about cleaning up the brush border mainly, and also about biofilms. You can take the enzyme on an empty stomach for biofilms. Regimens there's no need to break it down into divided doses. You can just modulate it to fit your meal. Again, you're looking for all of those same improvements. Improvement in the fat within the stool or the steatorrhea, improvement in their lab tests, their nutritional indices, their fat-soluble vitamin levels. And then if they're failing therapy, assume they're either not being compliant or they're not taking it at an adequate dose. And then enzyme supplementation should also improve the symptoms of EPI, like abdominal pain, flatulence, and stool consistency. Okay, this is the meat on our bones. So I did a deep dive and I was trying to figure out what the hell do these enzymes do and when do we use them? And so these are the enzymes that we're going to cover. They're, what are we talking about? 1, 2, 3, 4, 5, 6, 9 separate enzymes. We're going to look at 9 separate enzymes and what they do so that you can have a little bit of confidence when you're prescribing your enzymes that you're actually giving them enzymes that target their actual condition. So alpha galactidase, this guy is everywhere. This guy is in a lot of our products, but it also goes by brand Beano. And here's what I'm gonna tell you, Beano, sometimes it's like magic. Sometimes alpha galactidase is literally all they need. So what is it breaking down? It's breaking down raffinose, saccharose, and verbascose, which obviously, we obviously know what all those are. Raffinose is in beans and brassicas. Saccharose is in beans, green beans, soybeans, and other beans. And then verbose is legumes and small amounts of really fibrous food. So honestly, you're thinking about alpha galactidase if they complain about they don't tolerate beans or they don't digest beans and they don't digest brassicas. Both of those symptoms, your brain should immediately shortcut to you need some alpha galactidase. Also, you can find these 3 things in virtually every other plant matter as well, in cereals and grains, in pulses, which is beans, in fruits, in nuts, and in veggies. But what I will tell you from a clinical perspective, if somebody tells you they do not tolerate brassicas and they do not tolerate beans, do not pass go, do not collect $200, just give them alpha galactidase, have them keep it in their purse. It might actually change their life. Well, maybe not that dramatic, but I always think the way I describe to my patients, what is a healthy GI? A healthy GI is an intestine that you cannot feel. You do not feel it digesting. You do not feel food stagnation. You do not feel discomfort. You do not feel bloating. You feel hunger and you feel the need to defecate. If those 2 things, if you're feeling anything in your GI between those 2 things, you know that there's a little bit going on with your GI that's not quite right. It could be a really easy fix just by giving you alpha galactidase with your brassicas and your beans, and then you don't no longer feel your GI. And I wouldn't even bother fixing anything. You know what I mean? Like, why dig deeper if it's such an easy fix? If that doesn't fix it, then you have to think harder. This is a really great study just on alpha galactidase and gas production. So basically, we fed these people a diet that had high, those 3 basically high fiber foods. And we either gave them 1,200 milligrams of alpha galactidase, 300 or placebo. And we saw that, from placebo, 300 worked, 1,200 worked much better. And we were actually looking at how much gas production they made from the same diets. Glucomannose. Glucomannose is an enzyme that is in starches. It converts starches to glucose. So it breaks down potato, wheat, rice, corn, and veg. It's generally measured in AGUs, and it's a useful enzyme for somebody who struggles with high starch meals. Oh no, I eat paleo because grains I don't really tolerate them, so I'm not going to do it. I mean, my first question is that true? Do you not tolerate them, or do you have an enzyme deficiency? And if you have an enzyme deficiency, I'm going to start you on a glucoamylase first. Lactase. Okay, this one is like low-hanging fruit. Lactase is the enzyme that breaks down lactose. Yeah. 70% of adults are deficient in lactase, and they require some kind of supplementation with enzymes when they eat lactose or to completely avoid lactose. The enzyme is called lactase fluorescein hydrolase, or AKA lactase. I will say that is a mouthful. I am positive I did not pronounce it correctly, but somebody told me, who told me, I think maybe Shar once told me, if you say it with authority, they'll just believe you. So the lactase is an intestinal disaccharide located in the brush border of the small bowel. When we're talking about lactose deficiency or a lack of production of lactase, what happens is at birth or even gestationally, human intestinal lactase activity will peak in the 3rd trimester, and it should be present at birth. And so healthy infants generally can break down lactase. It's part of their huge production of enzymes. However, after infancy, you end up with 2 phenotypes: lactase deficiency and lactase persistence. Lactate persistent people are individuals who continue to make high levels of lactase after childhood. Basically, we measure high levels of lactase as anything over 50 micrograms of total protein. And then lactase deficient people stop making lactase. And that could be a very quick discontinuation, or it can be a slow titration down where they just stop over time, absorb or digest lactose worse and worse. When you're looking at that level, low lactase is defined as anywhere as little from 10 to 15 micrograms per mil. And signs of lactose deficiency can start as young as age 2 and can happen also well into adulthood. This was a really great, study that looked at symptoms of supplementation with lactase before and after. So beta galactidase, basically that's lactase enzyme. And what we saw was a statistically significant decrease in pain, bloating, nausea, and diarrhea. Bloating, depending on the group. And I think these were phenotypically different groups. That's what those were. And, we saw a pretty good statistical significance, especially in the diarrhea group, but pretty much across the board as well. Okay, so those are like the bulk of it. Now we get into cellulases. And cellulases are a lot of different enzymes. There isn't like a cellulase like there's a lactase. Cellulases are a lot of different enzymes that act to break down the cell walls of fiber. Cellulases degrade insoluble cellulose into soluble sugars. The cell wall of a plant is very fibrous. It surrounds every cell of the plant, and it is a major component of the cell wall. The enzyme cellulase is essentially there just to help you digest plant fibers. It does not naturally occur in the body. There's no way for humans to make it. The workaround that humans have had to this is cooking their food, because the cooking process will obviously break down cellulase. And it helps convert cellulose into beta glucose, which is a fundamental form of energy within the body. It's important to note that cellulase is not a single enzyme. There are many different types of cellulases, and they operate on very many different pHs. Certain forms work better in more acidic environments. Other forms work better in more alkaline environments, but they really are, it's like this huge distribution of enzymes. This is going to be a little bit nitty gritty. We'll see if this is actually useful, but I found it interesting. So the first one we're going to look at is maltase. Why do we need to have maltase within a supplement, and when do we need to be thinking about using maltase? So maltase is an enzyme that breaks down disaccharides into glucose. It's found in plants, bacteria, and yeast, and it is naturally produced by humans within the mucous membrane. It helps us digest starches, and maltase helps convert into glucose. Maltase is found in a lot of processed foods, but also in some vegetables and fruits. So it's found in a lot of grains, breads, bagels, cereals, candies, crackers, energy bars. It's also found in like sweet potatoes, peaches, and pears. Maltase is interesting because there are 2 different peptides and 4 separate enzymes that have maltase activity. And having a complete maltase deficiency is quite rare. So somebody who doesn't tolerate cereals on their own, you want to think maltase maybe, but it's not likely that you're going to find a complete frank deficiency. They might have some function of their maltase activity. However, in 32% of the time, maltase deficiency is paired with lactase deficiency. So this is the kind of enzyme you're thinking about for people who react to both carbs and dairy. 9% of people will have a pan-disaccharide deficiency where they don't tolerate lactase, sucrase, maltase, or palanitase. But honestly, this one is more of a gradient. You're looking when you're taking your history, what is the thing that causes their symptoms? If there's some kind of carb plus dairy activity, then that's when you think maltase. Invertase is an enzyme that breaks down sucrose into fructose and glucose. It is released from the cell mucous membrane, and it's an important enzyme for people who don't tolerate table sugar or sweetened things. The other thing is it's often used in fondant, and it's also often used in candy. So if they don't tolerate those kind of treats, you're thinking about invertase. Sucrose deficiency or sucrose malabsorption, we're starting to kind of understand a little bit more of it. It's, with people on the standard American diet, it's really difficult to chunk out, is it sucrose or is it, glucose, is it lactose or is it any of the glutens that they're intolerant to? But we will often see sucrose intolerance with IBS, with bacterial overgrowth, with fungal overgrowth. There'll be both genetic defects in sucrose metabolism and acquired defects. And, these people are generally lean, low body mass, and they just do not like carbs or sweets. So you're thinking about invertase for those people. Pectinase is people who don't tolerate fruit. I mean, honestly, and there are people who do not tolerate fruit. Most likely that's due to a pectinase deficiency. Pectin is a jelly-like matrix, which helps cement plants together or the cell walls together. It also, the pectinases also come from aspergillus, and it's useful for people who don't tolerate fruit because they get more bloated, more distended, and it can either be a pectinase or a fructase deficiency. So it's worth trying this one. Xylanase is really interesting. Xylanase basically breaks things down to xylin, which will then be the byproduct of XOS. XOS, the prebiotic. It's found in high fiber foods. It is naturally produced within the body. Healthy intestinal tract should be able to secrete it. And basically, the xylanase allows you to use fiber as a prebiotic. It breaks down to XOS, and that seems to push more beneficial bacteria or more beneficial microorganisms within the microbiota. It also helps with their fermentation. And so it helps secrete short chain fatty acids throughout the intestine, which helps improve digestion as a whole. And then hemicellulase. This one's by far my favorite, mainly because of its effect on candida. So hemicellulase is a form of cellulose that is part of the cell wall. And it's made in the human, it's not made in the human GI tract. We rely on microorganisms in the GI tract to produce it. It has the ability, just like xylanase, to boost prebiotic activity. So beta-1,3 glucan is part of the cell wall in Candida albicans. And it seems to be the part that makes biofilms. And biofilms are one of the reasons why Candida is so difficult to control and fungal overgrowth takes so long to treat. Biofilms make Candida albicans resistant to antimicrobial treatments. So I can throw all of the drugs at them, but if they have enough beta-1,3 glucan, I can't touch them. Hemicellulose gives me a fighting chance. So this is a really great data point. This is an in vitro, so it's on a dish where they took Candida albicans that had active beta-1,3 glucans, and they treated with either fluconazole or fluconazole and hemicellulose, and they tracked that treatment for hours, I think. And basically what we see is control that had no treatments. This one had just fluconazole, and this one had, the biofilm matrix had fluconazole and hemicellulose. And what we showed, this is not a great image, I'm starting to realize. What we showed was basically I'm seeing how it's doing. This is the log of 10, how much we found. All of them were treated with fluconazole, and then some of them were treated with biofilm hemicellulose. And what we see is there was a ton of fungus initially, and then we see a decrease within the biofilm matrix as time goes on. So the enzymatic manipulation using hemicellulose does make our treatments a lot more effective. And they actually ran this trial with fluconazole and amphotericin B. And what they found is that when you add hemicellulose to the treatment, it is really helpful. So here are take homes. Patients can be intolerant to fats, carbs, animal proteins, plant matters, and we need to tailor our treatments to what they're reacting to. So different enzymes can be utilized for different points of digestion. There is no such thing as a one size fits all in medicine, as if anybody needs to tell us that. That's kind of what we do best. And so we need to try a variety of treatments and use the one that fits the patient the best. You can either start with a PERT or a vegetarian one. If it's not working, switch or mix and match. If it's not working, also see if they're taking it appropriately and using the right dose. Okay, that's it. We've got 3 minutes for questions.
Okay. Excellent, Ilana. Okay, is there any, I'm just going to fire away. Is there any risk to just giving pancreatic enzymes presumptively without obtaining a fecal elastase to see if it helps?
The answer is no, not that I've heard of with the vegetarian enzymes. Yes, potentially with a PERT, and it can cause damage. If you go onto your Hippocrates and look at side effects of PERT, pancreolipase, there are side effects.
Mm-hmm. Okay, I have a patient with repeatedly low serum amylase and lipase. What clinical significance do you give to that finding? I'm not sure what symptoms they have or don't have.
Yeah, so the problem is that we don't have necessarily any clinical significance to amylase or lipase unless they're high. We don't have clinical significance with them being low. That what you're starting to look at is, do they have stool fecal elastase that's appropriate, and are they having malabsorption symptoms?
Okay. Are low pancreatic enzymes contributed to by low hydrochloric acid? We were taught a long time ago that correcting low HCl will help stimulate enzyme production. Also, any research on chewing time or dilution of stomach contents by drinking too much with a meal? So let's start with the first, HCl.
So here's my problem with HCl. When I did my last lit search on this, and I think it was probably a couple of years ago, there was not a single study in all of PubMed that looked at hydrochloric acid for digestion. There wasn't. If they were looking at hydrochloric acid, they were most likely with tube-fed patients. That's not a regular anatomy. So I struggle. So my take on hydrochloric acid is, I don't know, try it. If you feel better, great. If you feel nothing, you wasted a little bit of money. So I struggle with hydrochloric acid as a whole. I think more about digestive bitters, and I think more about food hygiene to improve it.
Wait a minute, your PubMed search was what?
My PubMed search was hydrochloric acid, EPI, hydrochloric acid, IBS, hydrochloric acid, dyspepsia, like.
Okay.
Yeah, I was looking for anything.
Okay, what about chewing time or dilution of stomach contents by drinking too much with a meal?
I just can't see who's going to fund that study.
Yeah. Do you like vegan enzyme products that contain HCl, or do you prefer to use its HCl separately?
I think
so. Go ahead.
HCl is not in my thinking. If they stumble upon it on their own and it works, then I'm really excited, but it's not where I start. It's not even where I finish.
and so you don't really do the whole HCl challenge testing?
I will say that here's my problem. When I was in school, I worked for biotics, right? And they would give you these recipe guides of like, oh, they have this symptom. So here's this recipe for 8,000 supplements that cost $400 a month. And they did that, take 1, take 2, take 3. And I did this. And I think I hit like 60 pills. I didn't feel any burning. And the only thing I felt was dyspepsia from having 60 pills in my stomach.
Right.
Yeah.
Any concerns of long-term use of digestive enzymes? Let's say these the plant-based enzymes.
No, and really it comes down to if they're indicated,
Yeah.
then I'm not worried. If they're not indicated, then I don't think they're necessary.
You speak of all these enzymes prescribed individually. Are you prescribing them in combinations? Or do you know? Yeah.
Yeah. So, what I'm looking at is when I'm taking my history, what are they reacting to? And then based on that, that's how I'm going to choose my product. What do they seem like they need more support on?
Your favorite digestive enzyme company? Just announce the disclosure and go for it.
So I am sponsored by Enzyme Science. They are sponsoring this talk, but I also think they have really good enzymes. And I learned about them because I had a patient come in and tell me about Digest Gold, which I actually think for a lot of people is just gold.
And it's known as critical digestion in the professional label. That's what I use the most of.
It's really gold for some people, not for everybody.
Yeah.
And also, HERT is also like life-changing. For
what
some
is?
HERT, like pancrealipase.
Oh, yeah. Right.
Yeah.
Yeah, you're right. Life-changing if they're in the weeds. Yeah. Let's see. Was there any other questions? I like the question regarding high fluids and meals, but we don't know the answer. So, do you have any concerns with enzymes with probiotics?
No. I think that it's really patient dependent.
Is there a common functional GI condition that causes EPI?
Yes. IBS, SIBO, SIFO, celiac, Crohn's, cystic fibrosis, pancreatitis, like 1,000 of them. And it can be its own thing.
The other name for the Digest Gold was critical digestion from Enzyme Science. Okay, those are the questions. Look at you. You were doubting your timing. But how to stimulate pancreatic production? That's the last question.
Yeah, I mean, you know what? Do the basic stuff. You know what I mean? Like, don't eat stressed. Give yourself time. Take digestive bitters. Try to breathe. Like, live like a human, not like a human today.
We are saying Digest Gold and critical digestion